one of Britain's busiest major trauma hospitals.
Can you open your eyes and look at me? Just need to see your eyes.
Filmed in January and February this year, during one of the worst winters on record.
You know, patients are waiting on the corridor that are really sick, but we can't do much for them because there is no space.
Have you got any beds? I know that it's tight, everybody's over.
This series documents a moment of crisis in the NHS.
The queuing to get in, and he's queuing to get out.
Can't do that one. We've got no bed for him and no potential bed for him.
Prompting actions as unexpected as they were unprecedented.
We are being asked to cancel any non-essential activity. So not cancer, not clinically urgent, but pretty much anything else.
We're being paid to work, but just trying to find something constructive to do.
I'm afraid it's bad news. We are going to have to cancel tomorrow. I'm really sorry.
We reveal the life and death decisions the staff must make.
The situation we've got is very severe. If we can buy her more time, then things should start to get better.
Against a backdrop of ever-increasing patient numbers.
There's never a day off for the NHS. Patients will still come and we'll still do absolutely everything we can for them.
Look at that, standing almost.
This is a place with some of the best specialists in the world.
The aim is going to be to try and grow your jaw and reconstruct the lower part of your face.
Where despite everything, lives are transformed.
It's been a long journey, but I think we're at the end now.
We were able to take, I think, probably all of the tumour out.
Look around. These are human beings. They're not numbers. They're not targets. These are your parents, your wives, your children. You know, treat them like that.
So on this Monday morning, we have got 13 patients, of which 3 are intubated and ventilated, and the others are all high dependency. We have got 1 booked admission to come in, so I'm going to say we haven't got any beds at this moment in time.
Following an increase in respiratory illnesses over winter, the Pediatric Intensive Care Unit at Queen's Medical Centre is full.
Week after week after week, we've been above 100% occupancy, and it's been utterly relentless. We look after the sickest children. Almost every child that comes in here has parents who think their child's going to die.
Adults RTU have got, I think, 6 elective admissions, and they've asked me to ask you if we could consider taking one of them, who's an 18-year-old. I've told them that we may be able to assist, but we'll have to review it in the morning.
Right. We've got two letters booked tomorrow.
The unit only has 14 beds to look after children from across the region.
Every day, the first questions I get is about bed capacity. Can we do this operation? There's a patient in another hospital who wants to come. What do we do?
So we'll review it in the morning.
We'll see what happens overnight. It's not a no, but it's just we'll see how this. How do we take the risks for the next 24 hours? Because if I only have 1 bed left, if I fill that with a patient for an operation, of what happens if in 4 hours' time another patient comes in through A&E? How do I balance all these conflicting demands? So we're stretched to breaking points, and there's 1 patient in, 1 patient out. So we'll give her a once-over now, OK? So we'll take you to the quiet room and have a proper update, you know, bit by bit, that we can talk about it.
OK.
4-year-old Esme has taken one of the last beds on the unit. She has a life-threatening condition called sepsis, which kills around 1,500 children a year.
So that shows that her heart is pumping nice and strongly at the moment, yeah? And we've actually got room for a bit more fluid within her. So we're going to give her a small amount of fluid now, and that will help her circulation a bit more.
OK.
Esme was rushed in from Hull, nearly 100 miles away. The units closest to her home, in Sheffield and Leeds, were both full.
I've seen her hands and her feet. OK. There is circulation into her fingers, but it's, you know, it's slow.
Yeah.
Sunday was a terrible day where we didn't know what was going to happen with her. Following the ambulance coming was probably the scariest drive I've ever done.
Yeah, it was a really scary day. It happened really quickly. She went downhill really fast.
It can happen to any one of us. The thing with children is they react quickly. A child, a baby who can be well now could be extremely unwell in 1 or 2 hours. Sepsis needs urgent and aggressive treatment.
Doctors have put her into an induced coma whilst antibiotics fight the infection.
There's a level of sepsis called septic shock, and that's when the body starts to divert blood to its important organs. And by important organs, I mean brain, heart, lungs, kidney, liver, that kind of thing. You can see the purpleness. That means that the blood has stopped in the purple bits. And the same here, you can see your fingertips are really quite purple up there. The organs the body cares about least is fingers and toes. And that's why in some patients with extreme septic shock, they'll shut down their blood supply to their hands and their feet. That's almost a bit of self-sacrifice when the body is in so much trouble.
With very little blood going to her hands and feet, there is a danger her fingers and toes may need to be amputated.
This transwarmer's a bit cool now. Keep your hands nice and hot, yeah? Her hand ones are now cold, so just have to keep on replacing them.
Yeah, that's not a problem.
Right, wait. OK. That's what I said, you know, her fingers and toes, they're my priority at the moment. I'm quite worried about the tips of her middle fingers. They're really quite purple. But I can't tell. I really can't tell, yeah. And at the moment, it's still up in the air. If this may get significantly worse, it might all get better.
Right, OK.
Yeah. So there is a risk of digit loss.
Mm-hmm.
I can't quantify that. I can't tell you how much that would be.
Right. But ultimately it's just a case of waiting and see.
We just have to wait and see, yeah. We're doing everything we can at the moment to push blood into the tips of the fingers. OK? I'm very confident now because you've probably been asking yourselves this over the past few days, but I'm very confident she's going to survive.
Right, OK.
That's important for you to know.
That's the most important thing, yeah.
Yeah. Clearly, there are days when I can't switch off, and there are patients who really get under your skin, and that's difficult. That's what children's intensive care is. You can be with her, you can sing to her, you can play her music, you can do whatever you like. Just stay with her and massage those hands and feet as well. In a very dream-like way, she can probably hear you and appreciate you're there. Yeah. She won't be able to respond. She's still very unwell. Mm.
She was totally well, and then we noticed in her face she was just staring into the corner of the room and she wasn't talking. And then she started getting a temperature, and then she got progressively worse. She was getting dizzy and she was confused. And then I noticed she got this rash.
Initially, no signs of anything, to suddenly being in intensive care in Nottingham, and then to be diagnosed with having sepsis as well. It's massively scary because you never think it's going to be your own child that gets it.
You just cling on to any little thing, just keep you going, really.
Hello, Esme. Yeah. Daddy just put some special cream on you to make your hands a bit better, OK? As a dad, you feel like you should be able to do anything, look after her. You feel a little bit weak when you break down a little bit, but it's sort of your daughter, isn't it? So you want her to be well. Well, that's all in there, Esme. Just turn your hand over. It doesn't really feel like you're there. It feels like you're almost, to me, like floating. When you're walking, you don't feel like you're actually here. You're sort of aware of what's going on, but you don't take it on board because you can't prepare yourself. Just from the inside, OK?
We're very worried about her hands. And what we don't know at the moment is what state her brain is in. There's still a long way for her to be going.
In addition to admitting patients from outside the region, Patrick also faces pressure from within the hospital.
I know that it's tight, everybody's over, so I think we'll just have to push you over for the time being, and then I'm going to see what stuff I can find for the late.
The neonatal unit looks after premature and seriously ill babies. When they are old enough, they should move to pediatric intensive care.
The neonatal team have such skills now that more patients survive into childhood, and they are often left with complex medical conditions, which means they use our services and much more.
Patrick regularly meets with colleagues to discuss the babies needing to move to his unit.
Thank you for coming. So this is either our third or fourth one of these meetings, brought about by discussing how we move our babies from the neonatal unit onto paediatric critical care or into the children's hospital.
This winter has been extraordinary. We've been hitting well over 100% and up to almost 120% week on week on week. And the pressure has been unprecedented. So we currently have 6 long-term patients, and really we don't have a discharge date for any of these 6, and so there's no movement for the foreseeable future.
We are still in a situation where we are full and therefore still moving babies out of Nottingham.
Fundamentally, there's no easy answer, and there are patients losing out on all angles and all sides. The technology we can give to these patients, which keeps them alive, is fantastic. But actually, there are costs you pay. There is a societal question here which becomes extremely complicated. The question is which children should have access to such intervention. At the moment, we're doing the best we can with the resources we have.
Are there enough resources?
No. Intensive care is all about buying time. Yeah? She gets herself better, and we buy her the time to get through this. Now, the blood tests indicate that if we can buy her more time, then things should start to get better.
22-month-old Amea spent the first 4.5 months of her life on Nottingham's neonatal unit.
She was born 16 weeks early, so she was a 24-weeker. It all started really with me having pain, and the pain progressed one night and I started to bleed. So I just rang into the hospital and they said, oh, you need to be in the labour suite. And to cut a very long story short, I'd been put onto the ward, I'd gone to the bathroom and thought I was passing a blood clot because that's what had been happening, but it wasn't, it was her. And so I caught her. Yeah, I stood up, caught her, opened the door, I'd been shown where the emergency button was and hit that, and that was it, really. When you look at the pictures of her when she had just been born, and you look properly and you can see she's perfectly formed, just she was the size of my hand. She weighed 735 grams, but perfectly formed.
Amea's prematurity has resulted in her having long-term medical needs, including chronic lung disease.
The same way as the elderly patients are living longer, the very unwell, complex children, they're living longer as well, which means they use our services much more.
She has spent nearly half her life in hospital at a cost of over £1 million. She's been rushed in this time with pneumonia on both her lungs.
The situation we've got is very severe, isn't it? You know, and you know that. I mean, no. 79 is not acceptable unless we can't get it higher.
The levels of oxygen in Amea's blood, known as SATs, have dropped to critically low levels.
Normal patients would have saturations in the mid to high 90s, and hers from the high 70s. That gives us no margin of safety. Eventually, the heart muscle won't have enough oxygen to pump anymore. Okay.
So do you want to go conventional or oscillator?
To get more oxygen into Amea's blood, Patrick will transfer her onto a specialised ventilator called an oscillator.
I'm going to change her to the oscillator now. And see how she likes that.
The oscillator delivers very small breaths very rapidly. But the process of switching her from one form of ventilation to another could make her oxygen levels drop even further.
Are you ready? Once you're on, Patrick, we can disconnect the ventilator. Right, 1, 2, 3, clamping. Unclamping.
Okay.
Right, let me just get this bit.
Okay, I'm just going to watch the stats and monitor it.
Okay.
If the level of oxygen in her blood drops below 60, she's in severe danger of a cardiac arrest.
You can move the oscillator in, yeah.
You want the oscillator in? I don't know if I dare look at the pressure. It's 60, Patrick. Good girl, darling. 68. Into this minute.
Mm, 24 is too high, isn't it? Ready? Play up. Below 60.
I'm going to pinch. I'll just pinch.
Below 60. Time.
Got a higher amount. 63.
I was going to bail out if the saturations go below 60. She hit 61, now 63. We'll give a bit of time, okay. Obviously 60 is not great, but I know I'm just going to give a bit of a chance now to sort herself out.
So she's connected to the nitric, is she, and
The nitric and the oscillator, yeah. It's 64 now, so it's slowly, we'll give a bit of time for this mode of ventilation to work.
She's been through it many times, but every time it happens, it's very fresh, and it's difficult seeing her like that. It's the waiting game's hard. Fingers crossed she'll pull through. She likes to put us through it.
Just sneak in and hold her hand.
Both our girls are an inspiration to us. We're used to roller coasters with Amea, but today, probably the biggest roller coaster I feel like we've been on. I think when you've got your daughter there fighting like she is, then you can't give up.
You always know when a patient's in trouble when your horizon reduces. And I think at the moment we're dealing with hour by hour as opposed to day by day or week by week.
For children's, as you know, we had some real challenges this morning with our crit care capacity. I guess my ask from this meeting is, if we get any acute admissions in ED through resus that require a crit care bed, can you give us a heads up?
The unit is full, but they must still try to accommodate children arriving for major surgery.
Looks like our surrounding trusts are black, so it means we are struggling to get a number of repatriations back to the right place, which is putting pressure on surgery particularly.
How are you feeling? A bit nervous. Be fine. I know it's a lot to take in. I think it's just finally happening. Yeah. You've waited a little while as well, haven't you?
Today, 14-year-old Ella is due to have an operation on her back.
Ella has a double spinal curvature, so that means her entire spine will have fixed rods and then rods at the side to make her spine straight, or straight as they can get it.
You'd see other girls with normal backs and that, and it sounds silly, but like in teenagers and like in society now, it's like body confidence and how you look is a huge thing. So it affected me quite a lot because I just wanted it over with. I wanted to be normal.
Unless a paediatric intensive care bed can be found, Ella's operation may have to be cancelled for the second time this month.
We've come before at the beginning of January. There wasn't any beds, so we were sent away again. So this is the second time here. It must have taken your head a bit. I think it's been more of an emotional rollercoaster than it has physical.
She gets herself in the place that she feels she needs to be strong enough. And then, of course, when it doesn't happen, there's a bit of a crash.
We're just trying to find a space in PICU for some patients that at the moment we can only accommodate one. And we've got 3 potential patients for 1 bed.
And how are you going to solve that problem?
We're just looking to see if we can move patients around the Children's Hospital in the safest way.
It's the job of site matron Sharon to try and free up a bed in intensive care for Ella.
Morning. Okay, and any other repats that we need to sort out? Nothing today. We try not to cancel, obviously, because it's not just cancelling an operation for a patient. It's all that goes with the child, the family having time off work, the siblings, people looking after the siblings. So it's a huge thing to have an operation cancelled for a child. Harry and I are trying to sort out some transfers out of the ICU so that we can then make space for the 2 patients that need to go to critical care. It's just a bit of a 4-way move.
So we've got to make a decision by 10:30 to know whether the young lady for the scoliosis operation can go ahead or not.
You were shaking on the way down.
It's just a bit real. It's very hard for a teenager whose emotions normally are all over the place to be coping with this. It's a big thing.
Every child in paediatric intensive care requires one-to-one care from specialist nurses 24 hours a day.
It's a very different environment to come and work here, and I think that you have a lot of stress from the type of patients we're treating. You are dealing with families at their absolute most devastating time. You can see families have travelled for hundreds of miles for an intensive care bed. It's not unheard of for us over winter to have patients from even as far as Glasgow if they haven't got any beds up there. And what they need is they need to be back home and they need to be back in their local hospital where they're better supported.
Keep them asleep for tonight and then wake them up tomorrow.
3-year-old Alex was rushed from Crewe 4 days ago with severe breathing problems.
Probably try and get back nearer home as soon as we can. If it's okay, we're back to Crewe. But we'll see how we get on.
He had to make the 70-mile journey after 6 other intensive care units were unable to admit him as they were full.
Alderhay, Manchester, Birmingham, Stoke, Leeds and Sheffield. So that is 6 intensive cares, 4 and unable to take Alex. It's not unusual from what I hear from colleagues around the country. Everybody is full, everybody is running at 100% or more capacity. It is stretching everybody.
Doctors discovered enlarged tonsils were blocking his airway.
So, they've taken his tonsils out.
They said they were really large.
Which is good. But they were clearly worried there is risk of bleeding afterwards. So they've said, leave that tube in overnight, but the plan is to take it out tomorrow morning.
Single mum Lisa is staying with Alex, leaving her 4 other children with family and friends back home.
Just me and the kids. We make a good team. That's it, we stick together and that's the main thing. My 10-year-old and 9-year-old, like Leo and Ashton, they're just constantly, when's Alex coming home, when's Alex coming home? That's the thing, it's like, because we live so far away, nobody's going to be coming to visit us. I'm trying to split myself into 2, but like I've explained to them, they're older at the minute, so they understand that he's my priority at the minute, to get him better, to get him home again. Aye. So, fingers crossed.
We could triple up those 2, and that should free up a nurse.
Yeah, definitely.
But it would leave us physically full, so then there is no escalation bed available. So we're stuck, essentially. I can make a plan, but it's not necessarily safe, and there is no leeway in everything that.
Is that you or me?
It's me, I'm ready to take that. Hi, Charlotte.
It won't be over before you know it.
With intensive care still full, site matron Sharon will see if she can create a high dependency bed on the children's ward for Ella.
Good morning. Sorry to come unannounced.
We've got a bit of a problem.
We're juggling.
With the Scully patients.
Right.
So we're trying to come up with a solution. Is there any way she could come directly from theatre here?
The only way she can is if we can look at staffing with you. We need to have one person who will look after that patient and maybe have one other. Do we have that?
So if I was to give you an extra support worker, 3 + 1, would that be?
No, it'd be trained.
A trained nurse?
Trained nurse on the night.
So I might have a solution to that, because CAU have got 5 trained plus 2 untrained. So we could move one of those trained down to give you 4.
Yeah. Okay, that would work.
So then we could then admit that young lady back
So if
straight
we moved
back
Ella
here.
directly here from theatre?
From theatre, yes.
On the night shift.
On the night shift.
And obviously Ella's previously been cancelled because we didn't have a pick bed, so we are mindful to cancel her a second time.
Yeah. Well, we're very happy to help.
So I will sort the staffing out for you for tonight and for tomorrow. You take the patients, everybody's happy.
Yeah, we'll do that then. So we've got a plan for Ella. So we think we can get everybody in today, and then we just need to check for tomorrow to see if we can preempt anything that we might need to change. Yes, through winter, yes.
The plan depends on Ella having no complications during surgery.
So just had anaesthetic by the team on the phone, and they're not confident in going ahead with the 14-year-old scoliosis operation if there's not a possibility of an HD bed. So we now have 5 patients who are knocking on our doors. Okay. Is there anybody on HD who's stable to move?
Only
to the ward.
Or to the ward.
From us.
No.
Hi, it's Patrick here. Hi. So the answer is as long as you try your hardest not to send the patient to us, then yes, that's fine. We can work it out somehow. The current plan is that we are going ahead with all the operations. On balance, probably it's going to work. But if all the patients go badly in theatres, then we have a problem. It's uncomfortable, and it is cutting it fine, but we don't have any option. We do have to play the numbers sometimes.
And what happens if someone really sick comes into the A&E department in the next 10 minutes?
I then will look after them, and I'll talk to the nurse in charge, and then we'll make a plan somehow to sort it out.
Morning, hello. Right, well, I'm ready, if you're ready. Yeah, now you can walk round or you can ride on the trolley, it's up to you. Okay.
Having been backwards and forwards to the hospital, you're aware that absolutely everybody here doesn't want this to be cancelled. They feel very bad about telling you that it has to be cancelled. They're doing their utmost in really, really difficult circumstances. And if anybody here could do anything different to help that, we know they would be. So it seems like everyone's fighting to get the same outcome. And sometimes that's just not going to happen because the resources aren't there, are they?
Every winter we run out of beds nationally, and it's an ongoing and persistent problem. The resources are static and the demand is increasing.
Esme is a 4.5-year-old girl who presented to health and came across to us on Sunday early morning.
4-year-old Esme has been in an induced coma for 3 days to help her body fight a severe case of sepsis.
So her fingers and toes, both her upper limbs are still necrotic. The proximal part of her fingers are more necrotic than the distal. In her toes, all 5 toes of both limbs are more necrotic.
Patrick must examine her hands and feet, which are threatened by the infection.
Okay, so I'm just going to look at your hands, okay? So this looks much more purple today than, as in ready purple, than dark purple. Yeah. And I'm happy with ready purple. Yeah. And even this fingertip is less black than it was. It was almost black yesterday. Yeah. I'm really happy with this, okay?
Good girl, Ez.
Yeah, good, good, good. The tips of the left toes are the worst of all.
Yeah.
Especially the middle one, that's the worst bit, isn't it?
Yeah.
Okay. I'm not wanting to minimise the situation, but if you're going to choose a limb to lose tips of something from, then your non-dominant foot is the best option.
Yeah, yeah.
I'm a bit worried about the tip, especially of the middle toe here.
Yeah.
But my best guess at the moment is that it should be able to count to 10.
Good. That was my main concern yesterday. It's brilliant news. You want to go with everything, don't you? You don't want to have anything to worry about. So yesterday was it was happy on the one sense that she's surviving, isn't it? But then scary on the other hand that she could potentially lose parts of her limbs. And now we've got the doctors saying that...
Especially with her hands, because she loves in it right.
Yeah, she loves doing everything with her hands. She's a very clever girl. And to looking like, he's not guaranteed, but positive about all 10 digits. It's just amazing.
The things we're worried about is her hands and feet and her brain, okay? As far as her brain goes, she's still obviously deeply sedated at the moment.
The prognosis for her hands and feet is positive, but Patrick still doesn't know if the sepsis has caused any damage to her brain.
So the plan is that we're going to aim to wake her up tomorrow. She may take longer to wake up than expected. It may take days to wake up, it may take hours.
Right.
Right? So it's her turn now. Great, it's your turn now. Enough sleeping. We can do scans and we can look at brainwave monitors, but actually the best test of a brain is to wake her up and say, "Hi Esme, how are you?" And if she says, "I feel poorly, Mummy," well, that's a huge amount of brain activity going on there. We just have to see how she is when she wakes up.
Ella's spinal surgery is underway, despite there currently being no bed in paediatric intensive care. The team are hoping there are no complications.
Hi, it's Kirsty, one of the Junior Sisters on Critical Care. I'm just ringing to find out if you've heard anything about Ella.
We just had a phone call from theatres. Her operation went smoothly. Some blood loss, but that was treated, and she's stable enough to go to the ward.
So she can go there tomorrow. What I'll do is I'll move the patient from D33 up to E17.
It's pretty standard in winter to have more patients, and there are simply no beds left. So we just have to make it up on a daily basis. We sometimes have to gamble that patients don't actually have to come to us.
Hello there, it's staff nurse Helen in Theatre Recovery. We've got Ella with us. I'm just wondering if you've got her parents, please. Would somebody be able to bring them down, please?
That's all right.
You won't be able to from there, don't worry. So set it straight.
Yeah, it's all done. Back straight. That's it.
The surgery was free of complications, so Ella can stay on the children's general ward, monitored by a one-to-one nurse.
I think it might need a bit more yellow in it.
You want a bit more yellow? I can do that.
Amea is still on the unit recovering from pneumonia.
You got it?
Her big sister Talia is visiting her after school.
Which way? That way? There? Sure?
Her oxygen saturation is much better compared to where we were. We know these families, so we go through many months with these families, and we get very close to them.
Did I get all her toes? Yeah?
If she's doing badly, it makes it slightly harder for us to be able to cope with it.
Yeah? Okay. So we've got one blue and one orange. What now? Don't worry, I've got my eye out for you, Mum.
This is my mum's favourite colour.
Is it? Oh, you've made a very good choice then.
Mummy, Daddy, I want to give you these.
Oh.
Oh. Yeah, happy love day. Happy
No,
love
you
day.
have happy. You have happy.
Happy love day. How cute.
Dear Amea, we love you. Love from Todd. Yeah.
Oh, bless you. I think it hit me yesterday, and I think it will hit me again as the days go on. Just the situation that we've been in, and obviously we still are in, but. Come on then.
3-year-old Alex was rushed to Nottingham after 6 other intensive care units were full and unable to accept him. He is now well enough to be moved to a hospital closer to home.
How's it going? Hi, Alex. You okay? Good night's sleep? Oh, you're not very awake, are you? I mean, clearly he's so much better now, isn't he? And was.
So what's the plan now?
Well, the plan is we'll phone up crew and ask them exactly what they can offer.
Right.
Because clearly it'd be much easier for you to be closer to home.
Right. So we'll find out if we're going home or we're going somewhere else soon, Papa. Another trip.
I'd be good nuts. Because obviously you've got your other 4, is it? Yeah.
Yeah.
You want to be close to them, don't you?
Yeah, definitely, don't we?
Yeah. OK, I'll let you know. OK, thanks. Bye.
A bed is now available for Alex in Crewe, but the team must find a nurse to accompany him on the 4-hour round trip.
Right, so about Alex going back to Crewe. Can't have no repats nurse today, but I'll help us organise an ambulance so we can release a nurse to do that. So if we send the nurse out at the moment with Alex, then we'll still have capacity for 1.
No, because don't forget you're going to lose a nurse.
If we have a nurse in an ambulance, they can't be looking after a patient, in which case we'll be 1 bed down whilst the ambulance is out. And if we have referrals, we'd have to wait until that nurse is back, or just say no. So they might have to travel further away as well. So everything starts to domino away. But then suddenly there are patients all over the country who aren't in their nearest hospital.
After 5 days on the unit, Amea's condition has suddenly deteriorated. She has had a cardiac arrest.
Her sats dropped so low, it put a pressure onto her heart and she went into cardiac arrest. So she's been resuscitated and now the battle is to get those sats back up because otherwise we're going to end up with another cardiac arrest.
Overnight she was lying face down on her stomach and prone, so we've turned her over. We think it's perhaps shifted some secretions that she got in her chest. Her heart rate started dropping, but when we got to a heart rate of 40, we just instantly started doing CPR.
Just having some faith in what the doctors are doing and knowing they know what they're doing, but at the same time terrified.
You see we're struggling, yeah. Saturations are up and down and they are a serious problem.
To help clear her lungs, Amea needs to be taken off the ventilator. During this time, Patrick must help her breathe.
At the moment, what we're having to do is our consultant is having to manually be a ventilator as such. So he has you'll see there's a green bag and then that's attached to some oxygen. So that will attach to Amea's breathing tube and he's replicating the lungs. So as he's squeezing, he's actually replicating what he would like Amea's lungs to do.
The question is, what are we going to try as a ventilator? Ready, KP, 1, go. We've just put it back into the ventilator and we are in a much better state than we were. Her lungs feel much better than did. Hoping she'll be able to cope with these seconds. We need a few minutes to stabilise and to and for the change to take effect. So I'm not going to walk away yet.
No.
I'm very worried. We saw this morning how desperately fragile and unstable she is. Having cardiac arrest because you flip from your front to your back, that's pretty extreme.
Just be you and fight like you are, okay? You've got a big sister who wants you home.
I'm feeling really shattered, mentally shattered, and the stress is very high, but at the same time you just have to keep going. Although she's stable at the moment, we do know that things can change, so it is a case of that every minute counts and eventually every hour counts, and we don't know which way this will go.
Morning. So you've got 13 patients?
Yeah.
Nobody for discharge?
No.
OK. Have you got anybody going home tomorrow?
Possibly.
Lovely. Right. See you later. So in the morning, when I go round, if there are empty beds, I allocate those beds to the patients that are coming in so that I know exactly how many empty beds I've got for the rest of the morning. And then at about 11:45, I do it all again. And then again at 2 o'clock. And then again at 4 o'clock. So I'm constantly walking around getting an up-to-date bed state.
Let's keep you fit all this.
Yeah, saves me having to go to the gym.
How was your evening?
Rough, late, early. I was on call last night and was here till 1 o'clock, and then went home to sleep, was called hourly until 6 o'clock, and then came back in at 6.
Is that normal?
That's rougher than average night, but it's not unusual.
It's been 24 hours since Amea had a cardiac arrest.
I did the suction overnight, and then overnight I've had a bit more suction. She's also stopped the drug which stops her from moving, which is great. Yeah, so that's a bit of control handed back to her. Monday we had 2 racks of pumps going.
Yeah.
There's now only 2 pumps left. Okay. So it's a new day.
Yes.
And the plan for the day is to just gently nudge her, stress her out a bit, see what happens.
Yeah.
But flip her onto her back.
Yes.
See what happens.
Yeah.
Reduce the pressures, see what happens.
Yeah, just keep now.
And as much as you want to, and I want to, just sit back and just relax for a day or 2.
We can't, no.
We've got to keep,
no, I know. And that's how she is. She needs pushing.
And if we push, she may go backwards.
Yes.
But if we don't push, she'll never go forwards.
Yeah.
So we just have to try again. And then deal with the consequences.
Yeah.
The pressures have come down, the oxygen has come down. It is a completely different world to yesterday morning. She's at a state now where we have a bit of a margin where we can stress her a bit and see how she reacts.
It's all right, sweetheart. Everybody's here. Right, so we're going to give her a wash, and then we're going to flip her back over onto her back. But because of previous history, we're just going to take her time. Right, so she's going to go onto her side first. We'll go halfway, so 1, 2, 3, and then just pause a minute. Make sure everything's coming. OK, darling, and then we'll go all the way. Good. That's it, well done. Well done. That's it, let's put these on quickly. That's it, your mum and dad's here. That's it, well done you. Good girl, that's better numbers as well. We will try and come down on our oxygen later.
What kind of life can Amea expect to have?
With her lungs, I know she won't win Olympic gold at marathon. I know this. But then nor have I As she grows up, hopefully her lungs will catch up with her, but we just have to wait and see.
Hello.
Unfortunately, I can't give you a definite time for us to take the patient. I'm hoping hopefully in about an hour when we've got another patient out and then we've cleaned the bed space.
After 5 days in hospital, Esme is well enough to be moved from intensive care to a high dependency unit. She's been brought out of her induced coma.
So, as you can see, a little bit quiet.
Morning. Morning. How are you guys? Morning, Esme.
Now that she's awake, Patrick can assess if there's been any damage to her brain.
The brain's most important, and there's no good test for it. Doing a brain scan will tell us if her brain has had a bleed or has been starved of oxygen or something like that. Actually, functionally, I'll just wake her up and ask her, and she'll tell us. Good morning, Esme. Morning. How are you? Oh, good. That's good to hear. Are you tired? Good. Are you hungry or thirsty? Thirsty. You're still thirsty? Have you had some food as well? No. Would you like some food? Sorry? No, thank you. OK. If you do feel hungry, OK, you can tell your mummy and daddy we'll get you some food. You're still thirsty. What would you like to drink? Blackcurrant juice. OK. Good. Is it right if I have a little look at your hands and your feet? I'll be very gentle.
And then you can have a drink.
And then have a drink after that. Yeah? Is that OK? Good girl. Oh, really good. Can you just try to squeeze my finger really gently? Oh, good girl, well done. Brilliant. Seeing her wake up and ask for some blackcurrant juice, please, is just absolutely fantastic. As if she can remember that she should still say her pleases and thank yous. Well, that says a lot for how well her brain was working. That's a great brain test there.
There you go. Who's that? Is Mummy keeping hold of you?
I'm keeping you safe, aren't I?
Can Daddy cuddle you?
Not yet. Maybe later.
Not now.
No.
You going to sleep? Can Daddy talk to you? No. Just feel nice in Mummy's arms. How's your lips doing? Do you want any lip balm on yet? How's your feet feeling, Izzy?
Do you want Daddy to stop asking you questions?
It's amazing. Obviously, I'd like to cuddle her, but I can't yet. I'm lower down on the list, but it's a bit scary just to see that she's been laying down so long, so now she's almost like a newborn again because she can't even hold her head up, and Hazel's got support her. But it's a fantastic step forward that we can actually get her out and cuddle her like our daughter again.
Nice feeling a warm body in my arms. I've missed her so much. And I like feeling a warmth in on me. It just feels amazing.
She was right in your arms.
I kind of want to squeeze her more, but I'm not allowed to.
Yeah. 16 days after being admitted to hospital with double pneumonia, Amea is breathing on her own and well enough to go home.
Amea has been amazing. It's amazing, Amea. She's been really good. The progress she's made has been absolutely incredible.
We've come to say thank you and goodbye. We're going home.
Oh, please don't come again.
Oh,
we're so pleased.
She's an example of the highs of this job. And 3 days ago, she was desperately sick, as in absolutely on the limits of what's possible. And now it's just fantastic.
You know what she does? She does this every time. She like thinks, oh, just gonna push them to the edge and then
Come for a service and an OT and then... Every time she sort of beats any of these illnesses, it is a milestone because it means that she's getting stronger. So she should have a better chance of fighting it off next time. But, yeah. We know how worried the staff were, so we know how close it came.
thank you. All the best for everything. All right, you take care, yeah?
This care is extremely expensive, and for the individual, it's absolutely fantastic. And I'm fully supportive, and I'm a huge advocate of it. On the other hand, the resources are finite as a health service. And how do we balance this? How do we balance the resources which are put into one child versus the resources maybe for a whole population?
She has cost the NHS a huge amount of money, but there's no way she'd be here if we didn't have the NHS.